Hello, sir. It's already 4:30. With all your permission, I'm starting this session. Yeah,
Sure. Yeah.
yeah. Good evening, everyone present here. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, Dr. Satyajit P. Patnaik, sir. Let me share some of the achievement of the sir. Sir is a consultant urologist and andrologist, transplant surgeon, stem cell therapy, specialist prior in PRP therapy for an ex-urologist to Honorable Governor of Mumbai. And so, sir, today is going to speak on a topic. Let me share the today's topic. As today's topic is newer surgical treatment of BPH. Let me share the overview of the topic. Being prostatic hyperplasia, that is BPH, is a common condition characterized by a prostate gland enlargement. In recent years, newer surgical treatments have emerged as effective alternative to traditional procedure like transurethral resection of the prostatectomy. This newer treatment offer advances in the reduced invasive, shorter recovery time, and improved outcome. To explore about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Okay. So hello everyone, and I think this is my first talk for this group. Generally, we used to give many talks, and now also once a week we give a talk for public awareness as well as awareness of the general practitioners and other consultants. Now, see, if we see our Indian population, in the 50 plus population, benign enlargement of the prostate BPH is very common, especially nowadays it is becoming more common and younger individuals are suffering. And this is because majority because of the adoption of the Western lifestyle, more sedentary lifestyle, as well as some genetic factors. So let us first have a look at what is the prostate and the general anatomy of the prostate. So prostate is a male sexual organ. It is not present in females. In males, it is present in this location exactly below the bladder encircling the urethra, and it has got multiple functions. One of the major functions is secretion of prostatic fluid, which is a fructose-rich fluid, which is responsible for nourishment of the sperms, and it basically gives lots of nourishment to the sperms, and it is responsible for mobilizing the sperms through the ducts. And benign prostatic hyperplasia, which you can see on the right side, basically the prostate is enlarged and it is compressing the urethra and thereby obstructing the urine flow. So let us see what are the complications of BPH. Number one is obstructive uropathy, which is obstruction to the flow of urine, bladder hypertrophy or detrusor muscle hypertrophy, trabeculations in the bladder, formation of diverticulae, formation of bilateral hydroureter because of the retrograde flow of urine, increase in intravesical pressure, bilateral hydroureter nephrosis, formation of a post-prostatic pouch, which is also called as the Jackson's pouch, and formation of a stone in the post-prostatic pouch, and secondary infection or repeated UTIs. Let us know that BPH or benign prostatic hyperplasia is not a risk factor for carcinoma prostate, and CA prostate itself can occur without an enlargement of the prostate. So there are two different things, they should not be confused. How do we diagnose BPH? Whenever a patient walks into our OPD, how do we diagnose BPH? So initial evaluation, obligatory tests are take a detailed medical history, including the antihypertensives or any diuretics the patient is taking. Take a proper cardiac history, ask whether the patient is on any blood thinners, assess the symptoms by the IPSS score or the International Prostate Symptom Score or the EUA guidelines, and categorize the patient. So IPSS score, which we all measure, is 3 to 35, and IPSS score more than 18 is definitely bothersome symptoms. Physical examination with digital rectal examination. Now, digital rectal examination is mandatory. Nowadays, I think we are doing, and almost everyone is doing, a screening transrectal ultrasound to screen the prostate. Urine analysis by dipstick method is also a good OPD test. Optional evaluations of these are also important. A serum PSA is very important, which is prostate specific antigen. Now, PSA, the measurement of PSA is as such is controversial nowadays, because over testing of PSA is being done. Even young men in their routine health checkups, 20-year-olds, 25-year-olds are subjected to PSA evaluation. So let me let you know that PSA is not disease specific, it is organ specific. So prostate specific antigen is normally released by the prostate, and a high level should be alarming, but there are many normal conditions also in which, or non-cancerous conditions in which the PSA may be elevated. So the PSA can be elevated in urinary tract infections, recent digital rectal examination, any urethral catheterization or instrumentation may also elevate the PSA. So we should wait for some time after any of these events for at least 2 weeks before we check the PSA level. Now, flow rate recording with the help of uroflowmetry is very important. Residual volume estimation using screening ultrasound, pressure flow studies, ultrasound, and endoscopy of the lower urinary tract. If in case there is evidence of bladder outlet obstruction and decreased quality of life, then we can always discuss the treatment options with the patient. And the treatment options include pharmacotherapy. Nowadays, there are many advances in pharmacotherapy, different combinations of alpha blockers, 5-alpha reductase inhibitors, as well as antimuscarinics can be used to elevate the symptoms, or the patient may be discussed about a semi-invasive or invasive modality of treatment. Now, let us see the treatment options available. First of all, non-invasive. Now, the only non-invasive treatment options are either medications or shockwave therapy. So, shockwave therapy is the only non-invasive procedure which is used for BPH. It is also called LITT or low intensity shockwave therapy. Semi-invasive procedures include BOTOX administration to the prostatic urethra. So BOTOX or botulinum toxin or Onaport A or botulinum toxin type A is injected through a transperineal route under transrectal ultrasound guidance to the prostate as well as the prostatic urethra. It helps in relaxation of the prostatic urethra and thereby alleviates the urinary symptoms. LITT or laser-induced thermotherapy. We will see videos of all these procedures in detail. Rhizome therapy or steam therapy for the prostate, which is very famous nowadays in our country, and PROSTALIFT, which is stapler therapy for prostate. Whereas the invasive treatment options include thulium laser enucleation of the prostate or THULEP, thulium laser vaporization of the prostate for small prostates, thulium fiber laser enucleation of the prostate, which is the latest treatment option, and bipolar TURP or enucleation, which is available widely and which can be contemplated in rural areas where laser facilities are not available. So let us have a look at shockwave therapy for the prostate or low intensity shockwave therapy. Now the name itself is a misnomer because it's actually electromagnetic wave therapy. It is not electrical shocks but electromagnetic waves which are focused on the prostate gland. Whenever they are focused to the prostate gland, they help in improvement in the blood supply. They help in driving away the inflammatory mediators, and thereby the advantages are the therapy is without medication or surgery, short-term sessions, no anesthesia required, eliminates the inflammatory response to the prostate, and there is significant improvement in the urinary symptoms. Now, so shockwave therapy can not only be used in prostatitis, but it can also be used in BPH or prostatic enlargement because it helps in elevating the inflammatory mediators, reducing the urinary symptoms, and it also helps in arresting the growth of the prostate, and it also helps in improving the drug delivery to the prostate. Intraprostatic BOTOX administration is also a proven method of elevating the prostate symptoms. Now, this treatment was first started by us, and it is a very famous, especially in young patients who prefer not to be operated. So here is the transrectal ultrasound probe. We are visualizing the prostate with the help of a transrectal ultrasound probe, and here is the needle. As we can see, the needle has come, and we have reached the prostatic apex. We have to be very thorough in the anatomy of the transrectal ultrasound. At least the doctor should be confident in doing about 100 to 200 transrectal ultrasounds before administration of botulinum toxin. We administer 100 to 200 units on both sides depending upon the bulk of the prostate, and it is administered equally in all regions of the prostatic urethra and thereby to reduce the spasm and to create more passage for the urine to flow. This is totally safe. This is free of all side effects. And after this procedure, generally the patient is on periurethral catheter for 48 to 72 hours, after which he voids freely. Now, this treatment is not a permanent solution. It can be done in young patients who want to avoid surgery and want a quick fix. So every 2 or 3 years, this procedure may be repeated. LITT, this is the next option, or laser-induced thermotherapy. Now, laser-induced thermotherapy is one of the novel methods in which we just probe a laser fiber into the prostate and fire it so as to cause, mechanical apoptosis of the prostatic cells. So this basically helps in, vaporizing the prostate, or causes apoptosis of the prostatic urethra, and thereby it widens the prostatic urethra. As you can see, after LITT, the size of the prostatic urethra has improved, and thereby the urinary symptoms are relieved. Now, let us talk about the most famous treatment nowadays, which is RESUM. Now, RESUM is basically steam injection into the prostate, which is water vapor therapy or steam therapy. In this therapy, what we do is that we pass in a specialized cystoscope, with the help of which we pass in a needle into the prostate, and we inject steam at high temperature and high pressure into the prostate gland. Now, this causes aseptic apoptosis of the prostate tissue, and thereby shrinking the prostate and widening the prostatic urethra. Now, it takes about 1 to 3 months before the prostate is completely shrunken. The patient is on catheter after the procedure for 40 to 72 hours, after which he experiences the total benefit or the real benefit of the procedure in about 3 months, in somewhere between 1 to 3 months. The effect of this procedure is temporary. It lasts for about 4 to 5 years. So, but it is non-invasive. It is very less invasive. So it preserves the sexual function, it preserves the sexual sensation, and it does not cause retrograde ejaculation. So it is preferred in young men. Now, coming to one of the other treatment options, which is PROSTALIFT. Now, PROSTALIFT is a treatment option in which we pass in a specialized cystoscope, through which we pass in a specialized probe, and we fire staplers into the prostatic urethra. As we can see here, first of all, the stapler is being fired, and the depth of the penetration of the stapler needle is assessed with the help of transrectal ultrasound. And after deploying the stapler, it is tightened. The same procedure is repeated on the opposite side, where initially the prostatic gland is compressed and the stapler is fired. Again, the depth is measured with the help of transrectal ultrasound guidance. And after firing the stapler for sufficient amount of depth, it is again tightened so as to hold the prostatic lobes apart and to widen the prostatic urethra so as the urine can flow freely. As we can see here, before the procedure, the prostatic urethra was narrow, and after the procedure, it is wide enough because it is held separately with the help of the stapler pins. So this is a treatment option which can be reserved for elderly people, senile people, or people who are in ICU care, who cannot are unfit for anesthesia and are unfit for undergoing any major surgical or operative procedure. Now we come to the gold standard treatment for enlarged prostate, for huge prostates whose size is more than 100 grams. So this is thulium laser enucleation or THULEP procedure. Now, thulium laser was first introduced in the country by us, and we still use it. And although it is 5 years old, this treatment option, but still it remains the gold standard, because thulium laser, with the cutting precision, the bloodless field, as we can see, there is zero bleeding. So this can be used for patients with coagulopathies as well as patients who are on anticoagulants. Without stopping the anticoagulants also, we can use this treatment for enucleation of the prostate. Patients with cardiac conditions in which ecospirin or clopidogrel cannot be stopped, they can also be subjected to this procedure, and the recovery is very fast, because since this is an ultra focused laser, the depth of penetration is less and it causes minimal bleeding. It can be used for huge prostates, and it can preserve the continence as well as preserve the ejaculatory function of the patient. So thulium laser enucleation is one of the gold standards because it is quick, it can finish off, large prostates, about 150 to 200 grams prostate, we can finish it off within 45 minutes. And the recovery is rapid. After 48 hours, the catheter is out and the patient voids freely. And there is zero bleeding. There is no bleeding at all. So that, there is no need for blood transfusion. There is no need for stopping the anticoagulants also. And the entire procedure can be finished easily within half an hour to 45 minutes. So this was thulium laser enucleation. Now we come to vaporization, which is THUVEP. THUVEP can be done for smaller prostates which are about less than 100 grams or about 60 to 70 grams with significant obstructive symptoms. Here we just touch the laser fiber and vaporize the prostate gland. Here we are not cutting. See, we have just touched it and it is being vaporized. And this is called vaporesection. Vaporesection of the prostate. Mostly the lateral lobes and a little bit of the medial lobes can be vaporized. Again, there is zero bleeding and this is a very safe option for patients with small prostates. Now coming to thulium fiber laser enucleation, which is the latest treatment option. Again, this was launched by us for the first time in the country 3 years back and still remains one of the gold standards. As we can see, the laser plane is absolutely clear. There is zero bleeding. The precision is fantastic. And the depth of penetration of thulium fiber laser is just 2 mm. So there is no damage to the sphincter. The sphincter early release is possible. There is zero bleeding. So similar to thulium laser, thulium fiber laser is more precise, or I can say it is ultra precise, and it can be used for patients on blood thinners without stopping the blood thinner, because it completely enucleates the prostate without any bleeding. As we can see, it is a total bloodless field. Here we are enucleating the lobe. We can see the demarcation is very clear. The demarcation between the prostate and the capsule is absolutely clear. Here I would like to mention about holmium laser, the laser which was very famous about 10 years back. Nowadays, hardly we use holmium laser because the depth of penetration is less in thulium and thulium fiber. Also, the learning curve is very easy. So youngsters can learn very easily, whereas the learning fiber was very steep, or learning curve was very steep in holmium laser, because the fiber used to vibrate a lot and the tissue planes were not so clear. Also, people, see the lobe is enucleated and it is detached and it will fly off right now. And it is a total bloodless field. Whereas in holmium, the demarcation between the capsule and the prostate was difficult because the learning curve was steep. Whereas in the case of thulium fiber laser, here we can see that the hemostasis is excellent. And we have already achieved the clearance. So in thulium fiber laser for a prostate for about 100 grams, complete clearance can be achieved in about say half an hour to 40 minutes. Now coming to bipolar TUR or bipolar enucleation of the prostate, especially in rural areas, because in India there are many primary health centers which are doing a fantastic job. They are catering to a population of thousands. And because of financial constraints, laser is not available. So, bipolar TUR is always an option. Also, auto impedance cautery can be used and TUR can be done safely, or plasma kinetic cautery can be used. And transurethral resection or transurethral enucleation of the prostate can be done with the help of bipolar cautery. Again, monopolar cautery enucleation should be condemned because we use glycine or we will use distilled water in the case of monopolar cautery, and which can cause dilutional hyponatremia, which can be life-threatening. Also, the duration of the procedure is limited to 30 to 40 minutes, and there is tremendous bleeding. So we should not do in 2023. We should not do monopolar enucleation or monopolar TUR. If in case laser is not available, bipolar TUR or bipolar enucleation is the way to go. So to conclude, so the word should not be conclusion, but it should be a sequel which stands beyond, which is invisible as music, but as positive as sound. So we should not conclude in our learning ability. There should be no full stop to our learning, but we have to keep on learning and we have to keep on modifying ourselves. And so every next level of your life will demand a different version of yourself. So we need to keep on upgrading. We remember about 15 years back, bipolar, TUR, or plasma kinetic cautery was the gold standard, but it eventually got replaced with laser. And every 2 or 3 years, new laser machines are coming up. Rhizome treatment was not available. Nowadays, rhizome treatment is an option to younger patients who want to preserve their sex life, who want to preserve their ejaculation. So, the world is rapidly evolving. Newer technologies are coming up in urology and in medical field, and we have to cope up. We have to cope up with them, and we have to keep on learning and keep on progressing. So there is no escape to learning and upgrading yourself. Thank you everyone for your patient listening, and we can start off with some questions.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participant doctors on their practice also. Sir, we have received some questions, sir. If you allow, can I take this question with all your permission?
We can.
Yeah, the first question I can say for Dr. Anubhav, and he is asking, when are urinalysis and urine culture indicated in the workup of BPH?
Every patient, when he comes to the OPD, we do a dipstick analysis or a rapid analysis for urine nitrites and leukocyte esterase. And he is subjected to urine routine. If in case nitrites and leukocyte esterase is present and the pus cells are more, then every patient is subjected to a urine culture.
Okay, thank you so much, sir, for answering it really well.
Without looking at the culture report.
Okay, sir. Thank you so much, sir. I hope that Dr. Anubhav has received his answer. Moving forward, I can see another question from Dr. Zainab. She is asking, what are the complications of bladder outlet obstruction due to BPH?
Yeah, bladder outlet obstruction because of BPH. If in case it is neglected by the patient, it can cause renal failure. It can cause chronic kidney disease. The patient may land up with dialysis. It may cause repeated urinary tract infections. It can cause urolithiasis. It can cause a Hutch diverticulum. It can cause Jackstone calculus. You name it. All the complications of obstructive uropathy can happen. If in case it is acute obstruction, the patient may land up in retention of urine and may need catheterization. So when we check the patient in OPD, post-void residual urine should be checked for. The patient should be asked, is he straining for passing urine per rectal examination? And at least a transrectal ultrasound should be performed in the OPD channel.
Thank you so much, sir, for answering it, sir. Moving forward, I can see there is a couple of more questions. We will be taking last two questions for today's session. And from Dr. Bhattacharya, he is asking, what is the role of phenexobenzine in the treatment of BPH?
So we are discussing the surgical treatments. We are not discussing the medical treatments as well.
Okay, sir, but the question was from the doctor, but no problem, sir. Moving forward, we will be taking another question. And the question is, sir, how effective are 5 ARIs for the treatment of BPH?
Yeah, they are effective 5-alpha reductase inhibitors which prevent the activation of testosterone or prevent the formation of 5-dehydrotestosterone are very important. And if we review the literature, we have a study called as the MTOP study. So according to the study and according to the guidelines of the American and the European Urological Association, if in case the patient is asymptomatic or symptomatic and the size of the prostate is less than 50 grams, less than 45 to 50 grams, we start with alpha blocker therapy and monodrug therapy. If in case the size is more than 50 grams, then we can switch over to combination therapy, which is alpha blocker along with 5-alpha reductase inhibitor. There are two different types of 5-alpha reductase inhibitors available in our country. One is finasteride and the newer version is dutasteride. Now, finasteride can cause many complications or many side effects like derangement of the lipid profile and gynecomastia, and many cardiovascular effects are also present. So nowadays we don't use finasteride much. We use it in combination with dutasteride. So either cancellous with dutasteride or cancellous with silodosin can be used for patients who have prostate size more than 50 grams, and eventually the dose can be tapered and they can be switched back to monodrug alpha blocker therapy. So 5-alpha reductase inhibitors can be used in combination with alpha blockers to reduce the size of the prostate, and also in individuals, 5-alpha reductase inhibitors can be used in patients who have got large prostates. Before surgery, we can give it for a period of 2 weeks to reduce the vascularity of the prostate.
Okay, thank you so much, sir, for answering all the questions, sir. I hope that related to this topic, all the doubts of the participant has been clear, sir. And sir, if there is no more question I can see, sir, can we conclude this session with all your permission?
Sure, we can conclude.
Okay, thank you so much, sir, and hope to see you again with different topic in future, sir. Till then, take care of yourself, and thank you so much for taking out your precious time, sir.
Thank you.
We are closing. Welcome, sir. Take